Just like some of the other cases we've looked at so far and we will look at, we have a bit of extra content here. This is Elmer the Welder, never before seen footage. The following material is considered bonus material. It'll be useful if you have an interest in primary care, sports medicine, or other MSK-related fields. Topic 1. You're going to hear about scapular winging, and these are total MCQ bait questions for the LMCC. These are scapular problems arising from specific nerve injuries and are much less common than the functional problems that we see with painful shoulder disorders. Most often now, these are seen as complications of other surgical interventions. Breast surgeons, radiation oncologists, and ENT surgeons, this is a good slide for you. Topic 2, the real world. In the real world, there is often going to be a big gap between Elmer's referral and Elmer's consultation with a surgeon. The rest of the bonus material now basically deals with how to be an effective primary care provider for Elmer and how to act collaboratively with his future surgeon to make the most of this gap. One aspect of this is dealing with non-operative treatment in the form of supervised active rehabilitation. We've gone over in the main segment the advantages and rationales for it, but when it runs up against reality, there's some things to think about. First of all, with the patient. A patient is not going to benefit from active rehab if they don't buy in, if they have poor pain control, if they have lifestyle constraints, poor body knowledge, told that they need surgery and have embraced that message, there's a language barrier, or they simply can't afford it. On a primary care end, the provider may have discomfort with initiating and monitoring this type of non-operative treatment. They may also believe that there's no role for physiotherapy because the patient requires surgery, and they may not be effectively addressing the pain control issue. On the physiotherapy front, the therapist may be inexperienced with shoulder rehab specifics. They may stick simply to passive modalities, and they may not be individualizing treatment to the specific shoulder. The shoulder pathology itself may complicate the ability to do rehab. There's some pathology that's too severe for full success. Finally, the system does set up some barriers through lack of funding, limited oversight, no pathways, and challenges with access to MSK specialist care. You may have heard about something called platelet-rich plasma, which is the soft tissue magic juice du jour and has its vigorous proponents. I do not routinely prescribe it for rotator cuff concerns, and I don't feel the evidence is there. It is also not covered by public insurance. If a patient approaches me wanting to try it and they have the means, I don't stop them. The role of PRP may continue to evolve over time, so stay tuned. This is the other magic juice currently going around. I am not involved in the prescription or counseling about medical cannabis products. Anecdotally, some of my patients have really benefited from it, either as a pain reliever or as a sleep aid in the context of rotator cuff pain. Others, however, have experienced no benefit or find the side effects intolerable. There is a lot we need to figure out about the effect and delivery of cannabinoids. In the end, there's 3 things to remember about Elmer. First, just because he has been referred, he has not yet been fully transferred and he needs care from his primary care provider. Second, Elmer has health issues that need addressing if he's going to get the best possible surgical outcomes. Finally, one can advocate for Elmer if his situation is deteriorating and he would benefit from an expedited consultation. So principle 1 here, there's a few holding pattern care activities that can be considered. The first is making sure you continue to help with pain, sleep, and mood management, and the second would be getting up-to-date imaging if the symptoms evolve. Principle number 2 is that there are things that can be done to prepare him. So what about surgery? Surgery is good, but it's far from perfect for rotator cuff conditions. Negative prognostic factors include size of tear, chronicity of tear, patient age, active smoking, and poorly controlled diabetes. Elmer is a smoker. Elmer's diabetes is not well controlled. As you go through the rest of the foundational courses in your med school time, you'll have a better context to understand the systemic health effects of these 2 very common conditions. For our purposes, they are both bad for the shoulder in addition to everything else. Addressing these as much as possible prior to surgical consultation helps optimize the patient and avoids downstream delays or poorer outcomes. This is the end of the bonus material for this case. It also gives us a CanMeds moment for collaboration.